cause lesion in almost all the teeth. Secondary decays, short roots. So we'll plan for 4 implants. 4 implants or 3 implants?
3 implants.
3 implants. So after bridge removal, if some teeth are good, we can retain that. But tentatively we will plan for all the 4 extraction. If you see the bone is good, there is a lot of bone. So we are planning for lateral incisor. Okay. If you see, there is a concavity here, right? The label. See, the patient actually shaked the head during taking X-ray. You can see the double image. Already there is artifact because of the bridge. Upon that, the patient head shaking. See, the root outline is not visible clearly, right? See the labial concavity, but there is a lot of bone. If you place, so you have to keep finger palatally and drill parallel to the palatal finger. You can place a compressive 3.75 into 20. Okay. If you want to engage the nasal floor, you have to select 23 mm basal. Okay. If you put 20 mm basal, you will be falling short of the nasal cortical bone. If you see the nasal cortical bone here is around 1500, but just below the nasal cortical bone it is only around 600, 500, 400. Okay. So if you are planning for compression implants, you can place 20, but if you are planning for basal, you should not place 20. More likely it will fail. Okay, whether you place 20 mm basal or 70 mm basal, both are same. Okay, if you are placing basal, better get nasal cortical engagement in this case. Suppose the bone here is good, 1000, 1200, there is no need to reach the nasal floor. Okay, so you have to take a decision here whether you are going for a compression or. How I will decide is after extraction I will check the label plate. If there is no label plate, I will go for a 23 mm basal. The label plate is good, thick, somewhat decent, I will settle with the compression implant 20 mm max, but smaller diameter. Okay, why smaller diameter?
Longer.
Because it is lateral inside buccolingual width is small, so if you select a wider diameter, this buccal bone will resolve easily and gum precision. In the last class we discussed compression, interval implant distance. So I am putting one implant in 1-1, where there is a periapical rarefaction, cyst, labial perforation, all things are there. Okay. Yeah, this is the view which we were discussing, right? See now, this is the incisive foramen. You have already placed one implant in the lateral incisor. So between this implant and the incisive foramen, you have to place one more implant, which is practically difficult, and that is what we discussed in the last class. So better to avoid placing implant in the 1-1. Otherwise, you have to come here labially. Okay. Of course, you are going to place 3.6. We'll make it as 3.6. Okay. Now I am avoiding 1-1. So this is what I am again repeatedly. Here the width is more, but near the apical level, the ridge width, it is less, because the roots are converging apically, right? So even though there is a good distance between the implants at the cervical level, at the apical level they will be
close
touching
to
each other, close to each other, creating troubles, or if you are lucky they won't create any trouble. So we will settle with one implant on the right side. Okay. Now we will plan for the 2-1 implant. 2-1, there is labial bone loss till the apex. Since the bridges are interconnected, we cannot analyze the Okay, if their individual crowns, all will be mobile now. Okay, the roots are very much resolved. Periodontal issues, gum inflammation, pockets. So this is the problem with bridges. They cannot test the patient will be thinking my bridge is not mobile. Okay, but once you remove the bridge, all the roots will be mobile. So we will plan for 2-1. Okay. See the root length. See the root length is very small. Okay. Labely there is label cut is missing actually till the root apex. And the canal is quite big. So if you follow the palatal rule parallel to the palatal plate, you will end up in
perforating again. Perforation.
You will end up in nasopalatal canal. This is a nasopalatal canal. So here you have to place the implant parallel to the labial plate actually. Okay. See if you see in this view, it is almost towards the nasal midline, nasal septum area. So I am going like this now. We will check. So if I am tilting slightly distally, I can follow the palatal plate. Okay. But if I am tilting towards the midline, I have to come labially because the nasopalatal canal is in the midline. Okay. See, I have tilted slightly distally. If you see this view, there is no the canal is not present here. Okay. So if you want to avoid the canal, okay, tilt the implant distally and palatally. But if you want to place axially, straightforward, okay, along the root apex or towards the midline, you have to go labially. It will be safer. Okay, can you see? Can you see the canal is here? So you should not go palatally, labially. Labially you have got lot of length. This is the nasal septum, midline area. See, if you see the cross section, it will be like this. Okay, towards the midline slanting. Okay. Now we will plan for the 2-2. It will show in red actually. Okay. Two, right? So 2-2, what we can do is 2-2 we can slightly distally tilt it. Because if you place along the apex, you will end up hitting with the 2-1 implant. See the problem here, what you are facing here. The roots are very much close to each other in the apical level. How can you place implants without touching each other? Right? Imagine, can you place 4 implants here? You can place, but implants will be very close or even touching each other in the apical level, and the bone between the threads will resorb and patient will have problems later. Even I feel is only 2 implant is also enough. And what we can do is we can place 1 implant exactly in the midline. So it is safer from this lateral incisors implant. Okay, that is the better plan actually. So 1 implant in the lateral incisor, 1 implant in the lateral incisor, another implant in the midline. Exactly in the midline. You have to put an incision, open a small flap, and find the canal. Just labial to the canal, drill towards the labial aspect. Select a smaller diameter. Okay, 3.6 is enough, or even a 3.5 compressive implant also is okay. Exactly near the center. I think this is the better. Okay, or place implant in the 2-1, but angulate it towards the midline as much as possible. So if you angulate it towards the midline, it will be just near the nasal spine, just under the nasal spine. But the starting point will be in the 2-2, but ending it will be, apex will be in the midline. Okay, now we will place abutment and we will see. Now we will see the finally abutment check. Now we will cut only this lateral incisors, letter to letter. Okay. Now you can see the position. Now you can see the crest apically, how the implants are close to each other. You can see this is going palatally. This implant is not visible because it is going labially. So this is coming palatally. So the implants apex are, they are not close to each other, they are very, very far away. So when you are going to place implant in this kind of tight situation, place one implant towards the labial aspect and place another implant in the palatal aspect. By varying this, you can get a good inter-implant distance. See, when only when you are planning, no, we come to realize that placing even 3 implants, no, not touching each other is challenging. Otherwise, one more technique is place shorter implants. If you reduce the length of the implant, there is no chance for them to meet near the apex. The more they are longer, the more risk, no, they'll be hitting each other. If you place short implant, you can place even 4 implant also. We will just try that, just to check the theory. Okay. Okay. See, when I reduce the length and when I reduce the diameter, when I make more lateral as a distal tilt, the implants are showing they are good. Okay. Imagine if this implant is increasing in length, then somehow they are going to simple mathematics. Okay. They are going to touch each other in the apex. So however, we are going for only 3 implants. So as I already told, always see this view also. Okay, this is this is one implant, right? This we are going to delete. So 1 implant in the center, 1 implant in the lateral, and 1 implant in the another lateral. Okay. It is not that we cannot place 4 implants here, but it is not necessary. Why? 3 good implants with good stability is more than enough. Okay. See, already the root length is only 6 mm, 8 mm. We are going to give a artificial root length 20 mm, 20 mm, 20 mm. It will definitely succeed. Okay, now we will plan for the
Lower.
lower.
Plan lower.
Whenever you are extracting root canal treated teeth and you are placing immediate implant, you should be very careful, because if you leave some remnants and you are placing implants through the remnants may go into the osteotomy socket and they may create post-operative pain or bone loss and implant failure, which we discussed yesterday. Okay. Actually, what I thought is this may be a small, mild Bimax case, which they could have tried to bring the protruded incisors little bit back. Okay. So now we are actually dealing with a mild Bimax situation. So there is, beyond the apex there is bone loss. Whenever you see a line like this, what it tells? It tells the patient has shaken the head. Okay. Exactly at this moment maybe. Don't think it is some fracture or some development of abnormality. Okay. Before seeing the X-ray, we have to check whether it is correctly taken or not. Okay. See now. See, the roots are very close to each other, right? This root, this root, this root. Once you remove these roots and when you place the implant, they also will be close to each other, right? See, the crowns may be very wide, but the roots are close to each other because the roots, they converge apically. And not only that, the root diameter itself very small in the lower anteriors. So definitely when we are going to remove this lateral incisors, all central incisors, you may need only 2 implants. For incisor extraction, only 2 implant is enough because of 2 reasons. Because actually they converge apically, and the diameter of the root itself is very small, and not only that, they're close to each other. They're close to each other. Okay, naturally the inter-root radicular bone is also very less. So trying to place 4 implants after removing 4 incisors, no, it will it will lead to failure unless we are lucky and nothing is happening. Even placing 3 implants, it may lead to trouble. Either the implant will fail or the adjacent tooth may get into trouble. The implant becomes close to the adjacent tooth and it may give pain or some sensitivity. So actually the patient is having bridge from 4.2 to 3.3. So actually we are planning for saving 3.3. Okay. Maximum we are trying to save 3.3. Because the 3.3 looks okay in the X-ray and clinical picture also. But we are going to remove all the 3 incisors. They are having radiolucency, and this incisor also bone loss. We are going to remove it. The canine we are not going to remove it. Now we are planning for 2 implants and buccolingually thin bridge. Okay. Basal, see the bone here is little bit of cancellous. Here it is cortical. So if you are planning for basal, stop till here. Do not try to come till here. Okay. So it will be around 14 mm. Even if you extend 17, it is not an issue. Okay, because only 2 threads are going to be in the cancellous part, and the other maximum threads will be in the cortical part. Not only it is cortical part, it is the between the implant is sandwiched between the buccal and lingual cortical plate, tightly parked. So you will get good. So basal design also is good for the situation, even though in the apical area there is some cancellous bone. We are saved by this middle cortical bone and by the labial and lingual cortical plate. Or if you want to place compressive implant, placing compressive implant is not a good idea, because the adjacent tooth, no, they are with bone loss and with chronic infection, inflammation, the threads will be exposed to the bone defect here. So placing compressive rough surface implant is not a good idea. So basal 14 or 17 in the 4-2 area. See, after extraction we should cure it nicely. Here also the intramedullary bone is very cancellous, but here it is somewhat good, right? 900,000. So the basal will work. BC design will work. 14 or 17. Okay. If you select 20, it's not a good idea. Okay. Anyhow, after extraction we are going to do some minimal alveoloplasty, because already the bone will be thin labially, no bone. So straightly we will be into the basal bone. Can you see? After the extraction and cure it here, straightly we are into the basal bone. There is no alveolar bone left practically. This thin bone will come with the extraction. Okay? This thin bone, no? In the 4-2. This thin bone, during extraction itself it will come. Even if it is not coming, we have to remove it, because it is a thin bone, anyhow it is going to resorb, or in the immediate post extraction healing period it will come out. Okay, imagine during extraction if there is some crack here, this becomes a dead bone, very thin bone, less blood supply, it will come out as a bony spicule. So better extraction, good decent flap elevation, curate everything, remove this thin bone and place to basal 3.6, 17 or 14, something whatever it is. But it is a very thin bridge. Okay. Now we'll add up. Now we'll check the abutment position also. Okay. So almost they are quite lingual. Okay. Why they are lingual? Actually they are not lingual. The canine are buccal, because it is a bimax, little bimax. The canine to canine is little bit forward. Okay. The patient concern is that it should go inside. You have to think about removing canine, but the facial profile is somewhat good. There is not much in lip incompetence. Even if you give tooth position as such in the previous bridge, it will be okay. It is good. Okay. So the only thing you have to do is you have to bend the abutment little bit labial, right? Not lingual. You can see here. See, the teeth is labial, but our abutment is lingual. So you have to bend it little bit labial, not very much. Okay. See, planning in a panoramic OPG is one thing, but when you plan in a CBCT, when you see the CBCT, that gives more information. But actually, if you place the implant in the software, no, and add abutment to it and plan in 360 degree, you get lot of information. Definitely your plane changes, it improvises. See, this case, even without doing this kind of planning, a experienced person can go straight away and jump and do it. But if you do planning, spend few minutes like this, definitely you can give a better planning and treatment to the patient. Because these implants, they have to come for life. Okay, so nothing wrong in spending 10 minutes, 15 minutes in planning. Okay, so you have to get a good planning software. Blue Sky Bio is available free online. There is no charge for planning. Only if you want to convert this planning into some guides or something, you need to pay. So it is a free software available. This is a negative software available. Okay. Lot of free softwares available. You can plan any of this. Instead of just looking through the CBCT, if you plan like this, you will get a better idea. Okay.